All right, everyone, I'll give it a few more minutes, see if anyone else shows up, and then we will begin. All right, I will go ahead and begin. Again, I am Dr. Brad Rea, PGY2 pharmacy resident in pain and palliative care here at Hospice of Southern Illinois in Belleville, Illinois. Today I'm going to be talking about, excuse me, terminal restlessness a little bit, about how we can help patients and families go through it and how to kind of differentiate terminal restlessness from some things that we can actually help with, since terminal restlessness doesn't have a whole lot of good data as to how we can treat it. So to begin, if you want to go to this website, I'm going to have some poll questions for you guys to try to get some more interaction between me and you guys to see what you guys think about some questions as far as terminal restlessness. So to be pollev.com and then my name 270. And I'll give you guys a second to visit this website, or you can use your phone, as you'll see on the next slide when I actually have my first question for you guys. Okay, so here is my first question, and it essentially is what, well, I can't even read the question now because it's blocked, but what do you think about when you hear the term terminal restlessness? It's like a one word, whether it be restless, kind of in the name, or whether it's family problems, or what do you actually think about when you hear the word terminal restlessness? And we'll see if we get any responses up here. I haven't really used this poll everywhere in many other presentations, so I'm somewhat new to it, but I guess I can use my own as well and see if I can put something for myself. Okay, so it does work. So again, if you guys want to put any things in here about what you think about when you hear terminal restlessness. Okay, so we don't have a whole lot of turnout with that, but I will go ahead and continue on talking about what terminal restlessness is, how we treat it, how we go about it, and if I can figure out how to go to the next slide. Okay, well. Okay. So what is terminal restlessness? Essentially what it is it's behaviors at the end of life. Now, when we say behaviors, that's a very broad term. So what are we actually talking about with behaviors? So this is a very large range of behaviors that patients may or may not experience. This ranges from agitation, myoclonic jerking. They can have twitching or irritability. They can have impaired consciousness. They can go all the way up to having hallucinations, and it can be as mild as just tossing and turning in bed and seeming restless. It is actually the third most common reason for an admission to an acute care hospice unit or hospital at the end of life. So when patients reach this state, it is a very common reason to actually be admitted to a hospice, because it becomes very hard, not only on the patients, because a lot of times they're not very conscious with what is actually going on in their own state of health near the end of life, but really where it matters is the families and the caregivers that have to take care of these patients. They see how restless and how uncomfortable these patients are, and they want to try to seek help. And a lot of times the help they seek isn't with the hospice. Some other names for terminal restlessness that have been thrown around through the years is terminal anguish, terminal agitation, pre-death restlessness, and then there's some other ones too that I might bring up as we go through this discussion. So as far as how we treat this, unfortunately, there's not a good way to treat terminal restlessness. But before you actually going to treat terminal restlessness, it can be actually seen as terminal restlessness when it might be something like delirium. And if this delirium is caused, because terminal restlessness is sometimes thought of a type of delirium since they can have hallucinations and things like that. But if it's due to a medication or some other cause, we could actually reverse the terminal restlessness that patients experience. So essentially what terminal restless is in a nutshell. It happens at the very late times of nearing the time when patients are going to expire. It's typically not reversible as far as if they actually have terminal restlessness, but we can use some things to try to treat and try to manage some of the symptoms. The time frame of when it happens varies, but it could happen hours to death up to 48. So it could just be 1 or 2 hours before death. They might become very restless. Could be all the way up to 48 to 72 hours when they start experiencing the symptoms, even though there's still quite a bit of time left before they actually expire. So as far as that goes, the important thing to find out or to determine with terminal restlessness, if these patients are having symptoms of it, is to figure out the root cause. Now, if they are having true terminal restlessness, a lot of times there isn't a good root cause, but if we have increased their opioids or started a benzodiazepine, they start experiencing some of these symptoms, it could be a medication-induced delirium, which actually is reversible, when oftentimes when we think about terminal restlessness, it is not reversible. So what is the other side? The other side of terminal restlessness. So some patients actually have the opposite of terminal restlessness, and what we call is deathbed phenomena. Now you can see here I have listed 5 to 6% occurrence, and this occurrence is actually in patients that are conscious. Now most patients, when they are near the end of life or they are near the time of dying, they lose a lot of consciousness about what is going on around them. Only about 10% of patients regain that consciousness and can maintain normal human contact at that stage of life. So within that 10% of patients that regain that normal kind of consciousness and kind of follow what's going on in their life, 50 to 60% of these patients have what we call deathbed phenomena. So what is this? So this is visions of either past relatives, friends, religious figures, or visionary language pertaining to the travel to either the other side or the travel to their death. And a lot of times it's actually really beneficial. And research kind of says that if patients do have deathbed phenomena, they often experience a death that is more sound and more, or I should say, is less problematic than patients that have either terminal restlessness or not. A lot of times, at least in the United States, what patients see when they have deathbed phenomena is past family members or family members that have expired, and they feel this comfort of helping to transition to what happens after life. Now, in other countries like the Middle East and things like that, the most common thing these patients are going to see is religious figures. So they might see Gandhi or some kind of religious figure to help guide them to the other side. Now, this is a somewhat rare occurrence, and the research about why this happens varies, but it does happen. So a lot of people might speculate, well, yeah, the deathbed phenomena might happen due to cognitive changes, even if they are conscious or not conscious. But the research really says that even patients that are fully conscious of their surrounding can have this kind of phenomena, which is almost more like hallucination, where they have help from some kind of spiritual guidance to help them move on to the other side. So this is something that I hadn't heard of prior to, and I haven't seen a whole lot of it, but it is out there, and it does happen to patients of all ages, races, and locations. So here is another question, which I would like some input in, and it essentially is, what percentage of patients have, or do you believe will have terminal restlessness in the last 48 hours of life? So the answers are either 15, 25, 40, 65, or 80%. So I will say before I get too far, there are different studies that have varying rates. There's one that I cited here, but as far as terminal restlessness goes, it is a decent proportion of patients that do experience this condition. Let's see. So we have 65%. Well, I will say that it's not quite as high as 65%. The study that I had found in reference says that approximately 42% of patients in the last 48 hours of life will experience some type of terminal restless symptoms. And as I said, it's more problematic most often for families than it actually is for the patients themselves. And again, okay, I'll have to cancel out this. Okay, so talking about terminal restlessness, as I said a little bit before, the one thing we have to figure out is it truly terminal restlessness? Because if it's not, oftentimes there are ways we can treat it. And really the big thing that we have to look out for is delirium. So is this patient delirious or do they have terminal restlessness? Now, there's a lot of causes for delirium. A lot of times patients in the ICU will have it, patients that are in enclosed environments, patients that are in unfamiliar environments, places that don't have windows or are very dark, patients that have a lot of people coming in and out that they're unfamiliar with. These can all be essentially inciting events to cause delirium. So what's the difference? Delirium is usually acute onset, which terminal restlessness can be as well, which could be or could cause some problems in figuring out which one are we really dealing with. There's also an altered level of consciousness. It's fluctuating. And there's disturbances in patients' orientation, memory, mood, thought, and behavior. The reason why it's important to differentiate these two is because delirium is often caused from a physical substance or a disease and is associated with increased mortality, which is a big thing that we need to worry about. So if a patient is started on new medication or for some reason they have some changes in liver metabolism or renal function, and they either have higher levels of medications or their physical status changes, they could be developing delirium, which if they do have delirium, they do have that increased mortality. And even if patients are on hospice, obviously we're not trying to expedite the process of them dying. We're trying to make them comfortable. So the whole do no harm still does apply to hospice patients. So if they are delirious, we do need to figure out why or try to help out. And as I list here, it is oftentimes reversible. As far as delirium. So as far as delirium and terminal restlessness, some other things that we have to think about are, other than medications, we have to think about what are some other causes that can cause terminal restlessness or appear to cause terminal restlessness. So opioid use or any medications that can cause cognitive dysfunction can look like terminal restlessness. Another thing to really look out for is dehydration and electrolyte disturbances. A lot of times, even patients not on hospice are dehydrated. They could have electrolyte disturbances. They could have a UTI, which causes some cognitive impairments. So it's important not to jump just because they're acting weird or different than they typically are that they have terminal restlessness. They could just have some other insidious event that's going on. So here's the DSM-5 criteria for finding out if they have delirium. So DSM-5 has recently been, it's been a couple years now that it has been introduced, succeeding the DSM-4. And really the criteria for delirium has not changed very much. You can see there's 5 criteria that they have to have, A, B, C, D, and E. And really the only one that was added from the DSM-4 to the DSM-5 was criteria D, which kind of makes sense anyways. So essentially if they don't have anything to account better for delirium, then they have delirium. You can see some other specifiers in here as far as substance intoxication delirium or withdrawal delirium. So those are different types of delirium outside of the typical ones that we're going to talk about. But just to kind of mention here how typically we diagnose delirium in these patients according to the DSM-5. So what causes delirium? Who's more likely to get delirium? And what's going to precipitate it? So unfortunately, males, at least unfortunately for me, males are more likely to develop delirium. As we age, we're more likely to develop it. visual impairment, and that kind of goes to unfamiliar settings. So if you're not able to see, or that also goes with hearing, you're oftentimes put in this situation where you can become very confused or easily confused. And these events can lead to the development of delirium, immobility, dehydration, and as I said, unfamiliar environments, windowless rooms. There's a lot of things that can cause delirium. Interestingly enough, you can see the precipitating factors that can also cause it in drugs. Now, one of the biggest culprits to causing delirium with the drugs and within drug classes is medications that have anticholinergic properties. So not only drying agents such as scopolamine or hyoscyamine or glycopyrrolate, but also some of our antidepressants, our TCAs, especially third generation or tertiary amines. These can cause delirium. But when you look at the data and the research, really opioids don't typically cause delirium. Now, what they can do is they can exacerbate delirium that is already there. And depending on the dosages, if you're on a very high dose of opioids, it can cause delirium. But really what it's going to cause more than anything is sedation. And really the delirium is going to be lesser likely. So other precipitating events that can cause delirium, obviously infections, metabolic disturbances, so electrolyte disturbances, low potassium, calcium levels that are very high, or some other electrolyte disturbance, hypoxemia, fecal impaction, so if they have a bowel obstruction or something like that, that can cause constipation, cause a lot of problems in their bowels and lead to delirium. And then drugs. So drugs are going to be the most important thing that I'm going to kind of talk about, and kind of how I've a little bit already touched on. So the pathophysiology of delirium, I'm going to go into this rather quickly because there's a whole lot we don't know about it, but delirium is typically thought of as a global cerebral dysfunction resulting in a generalized reduction in oxidative metabolism and an imbalance in several neurotransmitters. So any drug that interferes with neurotransmitter function can really cause delirium, but it's going to be really dependent on the drugs and the metabolites and what we're actually dealing with. So the one thing that has been found as far as the pathophysiology of delirium is acetylcholine. And that's why anticholinergic agents are more likely to cause it. It's usually dysfunctions in acetylcholine that is going to be the main culprit. Now, there are other neurotransmitters and things that do have problems and have been shown to be causes of delirium, but acetylcholine is that big one. And really the administration of anticholinergic substances, both in experimental animals and human subjects, have shown the characteristic manifestations of delirium per EEE changes. So the electroencephalograms actually has shown changes when they are administered of anticholinergic substances. Although other neurotransmitters have been implicated other than acetylcholine, such as serotonin, norepinephrine, dopamine, and GABA. So we don't exactly know why patients have delirium. We know it has to do most likely with neurotransmitters in the brain and some type of oxidative metabolism dysfunction. But as far as that goes, that's pretty much the basis of at least the pathophysiology of delirium. As far as terminal restlessness goes, there have been studies that have looked at the stages of terminal restlessness and what is the most likely cause of it. And what they've actually found is that there's two main causes of terminal restlessness in hospice patients and patients in general. And the two main causes, or the two main precipitating factors that are found in terminal restlessness, are pain and problem conditions. So problem conditions are typically not psychotic, but either depression, unsteadiness, or uneasiness at the end of life. So they're not ready to move on. They have psychosocial issues. They're worried about their families, how they're going to manage after they have gone. But these are the two main conditions outside of medications that kind of lead to terminal restlessness. So what these do, they essentially lead to a distressed mood. When patients are distressed, when they're not themselves, when they feel like they're out of control, when they're not able to do the things they were once able to do, they're more likely to develop this terminal restlessness. This study found that patients who had more problem conditions and more pain are more likely to have distressed moods, as you can see by the chart here. They also found that patients who experienced more pain and had more distressed mood had a higher incidence of terminal restlessness. So although these are two essentially precipitating factors that can lead to terminal restlessness. And in this study, these were the two that were found to be statistically significant. It doesn't mean that there aren't other confounding variables leading to the terminal restlessness. In this study alone, it was just pain and problem conditions that were statistically significant to lead to the distress mood that actually leads to the terminal restlessness. So going back to delirium, because I'm kind of going back from terminal restlessness to delirium because they are very common and they're going to be not necessarily co-occurring, but it's going to be important to differentiate. So as far as delirium goes, there's kind of two routes that delirium can go. It's either the hypoactive delirium or the hyperactive delirium. So hyperactive delirium is what you're most likely going to see, and it's going to be the easiest to diagnose because this is going to be more like terminal restlessness. It's going to be visually apparent. You're going to see that they're uncomfortable, that they don't really know what's going on, they're confused, that they're very agitated, that they're having different problems. And as you can see, as the path goes on, it can lead to hallucinations or seizures or comatose. So the hyperactive is the easier one to identify. However, it's not the only type of delirium. There's also the hypoactive delirium, where essentially patients are very sleepy, lethargic, they're very out of it, they don't really know what's going on, but they don't know how to express that confusion. They don't express their emotions physically. They keep it in, and it's very hard to diagnose these patients. A lot of times in the ICU, if a patient has a hypoactive delirium, they may think that their opioid, if they are on an opioid, it's too high, or their benzo is making them tired, or they're on Seroquel, it's making them tired. They're on some kind of medication, or they have some kind of disease that's making them tired, when in reality, it could be some type of delirium. Maybe they're in a very small, dark room with no windows in an unfamiliar environment. They had been admitted to the hospital. They were unfamiliar why, so they're very confused. They don't know what's going on, and they don't really know what's happening. This is a hypoactive delirium, which is much harder to treat. And quite honestly, as far as the guidelines go, most treatments are aimed towards hyperactive delirium. There's not really good guidance about how to treat these patients that have hypoactive delirium. Now, it could be due to medications, it could be due to opioids or benzodiazepines or some other culprit. However, as far as treatments outside of removing medications, there's not good guidance about how to do that. So back to terminal restlessness. So there was a study that looked at terminal restlessness, and they actually interviewed hospice professionals to say, what do you see causing terminal restlessness? What do you see as the biggest problems? As I said before, the two biggest that one study found was pain and problems with organs. Well, this one actually interviewed different hospice professionals. And as you can see here, one of the biggest areas that they found, or they believed to be the problems for patients in development of terminal restlessness, was psychosocial issues. So unfinished business, family issues, emotional issues, and then the physical, air hunger, dyspnea, pain, discomfort, medications. So really the psychosocial and the physical both have a big impact in the development of terminal restlessness, according to hospice professionals. And really the one we can kind of help with, and one we can help with both of them, just in different routes. So the psychosocial, that's going to be better for the social workers to deal with. That's going to be better with patients that are trained to deal with those issues. But family members may as well. And it's going to be important to try to separate the two. We don't want them feeding off of each other's worry about where the money's going to come from or how they're going to provide for their family, or things of that nature. As far as the physical causes of hospice, that's a little bit different. Okay, that's a little bit different. So air hunger and dyspnea, we can help with that with either oxygen or bronchodilators, depending on the reasoning for air hunger or dyspnea. But as far as like pain and discomfort, obviously in hospice, that's one of our biggest things we deal with. And if we can help get that under control, a lot of times it can help terminal restlessness. Now, it can also exacerbate it if we go too high, if we make them sedated. There's a multitude of routes that we can actually look at terminal restlessness to determine what the most appropriate route is. But really the two big ones that have been identified are psychosocial and physical, as far as perceived by hospice professionals. So what agents can cause delirium? And this can also essentially cause a false terminal restlessness, since essentially when we think about terminal restlessness, it's an irreversible condition. However, if it's a delirium that has been caused by a medication that's appearing like terminal restlessness, that would be more like a reversible terminal restlessness, although it's not really terminal restlessness. It's more of a delirium caused by either a medication or some kind of condition. So these are all causes of delirium. And as I said, the anti-secretory medications or medications with anticholinergic properties are the biggest cause of delirium. So opioids, they can cause delirium. There has been a case study of a 14-year-old boy that was on fentanyl that had been titrated up that did start to develop delirium with positive symptoms of it. And there is some experimental evidence to support that opioids reduce release of acetylcholine. Fentanyl was actually found to bind to muscarinic receptors in the brain, and oxycodone has been found in some studies to have anticholinergic properties, which could lead to the development of delirium. As far as anxiolytics go, we know the benzodiazepines, things of that nature, they are a pretty big cause of delirium. Not only do they increase the risk of confusion, falls, amnesia, where they kind of forget, but you're also having some other problems such as tiredness and as confusion. Antidepressants, typically these are going to be constricted or confined to the TCAs or tricyclic antidepressants, with the tertiary amines usually being more problematic because they have more of an influence on acetylcholine. The anti-epileptics or anti-seizure medications, pretty much all of them have been implicated in some way, shape, or form in the development of delirium. So there's really no safe option as far as anti-epileptics go, but they sometimes they are needed. I mean, if patients are having seizures. Steroids, here we're talking about corticosteroids, and typically the patients that develop delirium on these agents are patients that are on high-dose corticosteroids, especially at the end of life, whether it be for COPD or some other condition. As we know, steroids can sometimes kind of pump you up and make you feel more energized. Well, on high-dose steroids, this can actually lead to some types of delirium if they are on high doses. And NSAIDs, interestingly enough, all NSAIDs have been implicated in the development of delirium. I don't know the rationale behind that, but the research does say that NSAIDs have been known to cause delirium, interestingly enough. Problem is, even though these are causative agents, sometimes it's hard to identify which agent is causing delirium and the best way to treat it. Because a lot of times patients that, especially on hospice, are going to be on 1, 2, 3, 4 types of these medications at the same time. And it's going to be really hard to pick and choose which one is the best. My recommendation would be to start with the anticholinergics, since those are the agents most likely to cause delirium, and then go from there to the benzos and to opioids and kind of move down that way. So treatments for delirium. So the guidelines essentially say that, okay, neuroleptic agents are the best. And what I mean by that is the antipsychotics. When thinking about delirium, as I said a little bit earlier, typically they're only for hyperactive delirium as far as these guidelines go. The hypoactive, the more tired, somnolent patients, it's going to be a little bit harder to treat them because there's not a whole lot of good guidance about the most appropriate way to treat these patients. The guidelines also do not differentiate between reversible and irreversible delirium with regard to treatment. So some cases of delirium are irreversible, typically like terminal restlessness is an irreversible condition. One thing to think about before prescribing or recommending a neuroleptic agent for delirium, keep in the back of your mind that the FDA does have a black box warning on first generation and second generation antipsychotics that patients are at an increased risk for death when you're using these agents to treat dementia-related psychosis in the elderly population. So keep that in the back of your mind that, okay, there is a black box warning on these agents that they could have increased death when using them for dementia-related psychosis. So first generation neuroleptic agents, second line, benzodiazepines. They're definitely not first line. And that's because they can cause increased confusion, they can cause amnesia, increased fall risk, worsening delirium, worsening terminal restlessness. So they're not a first-line agent for delirium, however, they are a second line. So I would definitely recommend the neuroleptic agents first. Typically, first-line or first-generation antipsychotics are preferred, and that's because there isn't any evidence to support that second-generation antipsychotics have any increased efficacy over the first generation. And that's kind of where the line's drawn. There's not that the first generation are necessarily better as much as that there hasn't been proof to say that the second generation are more efficacious than the first. So what about opioids for the treatment of delirium? You guys might have caught that I kind of talked about this a little bit, but they really have no role in the treatment of agitation or delirium because they're analgesics with no anti-agitation actions. Now they do have sedation as a side effect, but it can't be reliably predicted from patient to patient. So if they are having a hyperactive delirium, and you might think, oh, let's give them an opioid because it'll make them tired and make them, relax a little bit. Well, you can't necessarily say that. Yes, it's likely it will make them tired, but the variety of patients, or with a variety of patients, we also have a variety of side effects. So even though you might be trying to make them tired, it might cause or might require very high doses to make them lethargic. It's not a good use for opioid therapy at all. And really, as far as treatments of delirium, it's not recommended at all. As far as pain, as I said, pain can lead to worsening delirium or worsening terminal restlessness. And on the next slide, I'll kind of talk about delirium in the dying patient. So how do we differentiate delirium in a patient that's just in the ICU with a acute condition that is undergoing treatment for a bacterial infection, they have delirium, versus a patient that's on hospice that has a week to live and they're at the end of life? Well, really, it kind of switches. It's no longer antipsychotics that are preferred. It's the benzodiazepines that are typically preferred in these patients. And that's because they have a shorter time left on here. So we're not as worried about some of the problems of falling, hitting their head. A lot of times at this stage in the game, hospice patients or patients that are near this stage of life aren't moving around very much in the first place. But it's going to be important to realize that benzodiazepines are preferred first-line agents. Now, can you use antipsychotics? And I'll say, yes, you can, but they're not first-line agents. Now, if patients are having terminal restlessness with hallucinations, or whether it's auditory or visual or both, sure, antipsychotics could be used. If you're using benzodiazepines at a decent dose and it's not helping the patients and they're still having problems with delirium, sure, you can try antipsychotics, but they are not first-line agents in patients that are dying. So in these patients, benzodiazepines would be the first line agent. And here's some different dosages and agents that are used in patients for delirium. So you can see haloperidol is first line. And the reason why haloperidol would be a first line agent as opposed to some of the other first generation antipsychotics is, although it has more EPS symptoms, so extrapyramidal symptoms, and it can cause increased QTC, it has very minimal anticholinergic properties. A lot of these other antipsychotics do have anticholinergic properties, so even though you're using it to treat it, in some ways it could actually exacerbate it, make it a little worse. Also with haloperidol, it has minimal sedation, so that can be good or bad depending on the reasoning and the symptoms the patient is experiencing, but it typically does not have very much sedation. Now when you look at some of the other antipsychotics such as chlorpromazine, now, this does have anticholinergic properties. This is more sedating. This does have some other problems with it. So typically haloperidol is first-line agent, and then you might go to chlorperazine or something like that. As far as lorazepam, midazolam, some of the benzos, typically we'll start with lorazepam, a relatively low dose and titrate as needed. You could use midazolam, but lorazepam would be a first-line agent for me. It's been around for a long time. It's cheap, comes in a variety of forms and routes. You can see here they have phenobarb and propofol in here as well. Now this is going to be, at least the propofol, that's obviously going to be in a hospital situation, typically in the ICU under tight control, since propofol infusions typically are. But here's some other things that we can use if needed in these patients that are terminally restless. So this next, first I want to apologize for this slide because it is very busy, but it is somewhat important, and I think it does really help guide clinicians in determining which route do we go, how are we going to treat these patients most appropriately, and where are we going to go from here. So you can see here there's two routes to go, and it's essentially either going to the right or going to the left. So if it's potentially reversible, you can see we go down here, we have goals of care. Essentially, we determine hyperactive, hypoactive, first generation antipsychotics. We'll go down and we'll kind of figure out what the best route is. Now, this is going to be in cases of delirium caused by medication or some kind of electrolyte disturbance that isn't reversible. Really, what I'm talking about here with terminal restlessness and patients like that is going to be this irreversible cause of delirium. So when they are irreversible, we're going to have to palliate these symptoms. And really, there's going to be two different routes we can go depending on their symptoms, the hypoactive or hyperactive. So typically what we're going to see is the hyperactive. If they are hypoactive, it's going to be hard to determine if it's actually delirium that they're experiencing or if it's the opioids they're on or the benzos that they're on. So we'll kind of stay with the hyperactive situations. So you can see here, there's two routes here. So there's either irreversible due to active dying. So this would be our hospice patients near the end of life. And you can see here benzos, phenobarb and propofol are here too, but really that would be more in a hospital situation, and you can taper as appropriate. Now, if they are irreversible due to other reasons, whether the patient no longer wants to receive care, so they're going to be admitted to hospice, if some kind of organ failure that's irreversible, then we're going to go more towards the antipsychotics, benzodiazepines, and taper those as appropriate. So there is a little bit of difference between treating delirium that's irreversible at the end of life and not at the end of life. And that's essentially saying what's the best first line agent. It's either going to be a benzo or an antipsychotic. So as far as some of the conclusions, terminal restlessness can be reversible. Now, I say that with a grain of salt because really patients that have terminal restlessness that's reversible, it isn't really terminal restlessness. It's usually some type of delirium that's brought on either by a medication or brought on by some other condition, whether it's electrolyte disturbance, physical organ failure, liver damage or liver dysfunction, kidney or renal dysfunction. These types can be reversible if it's due to something that is reversible, but terminal restlessness by definition is not reversible. It's that condition that either starts up to 72 hours, up to the last couple hours of death and kind of persists through death. We don't have really good treatments for terminal restlessness. We have options to prevent it by either removing medications that might be causing it or doing something like that. We can help treat some of the symptoms of it with benzodiazepines and things like that. But really, we can't treat the terminal restlessness by itself. It's one of those conditions that we don't have a lot of good options for. We just palliate most oftentimes. And over 60% of dying patients experience cognitive impairment. So really finding out who is delirious and who's just having some kind of cognitive outbreaks, it's really hard to differentiate those people. Really, as far as terminal restlessness goes, prevention is going to be the best. And how do you prevent terminal restlessness? Well, that's going to be a multidisciplinary action that needs to be done. We're going to need social workers on board talking to the patients, talking to the families, figuring out what's most important to them at the end of life. Is it making sure their families are well cared for? Is it making sure they've cleared up all their bad things they've done in their life by having to apologize to friends that they may have wronged in the past? Is it wanting to be close with God and having a pastor come in or a minister come in and talk to them? Figuring out their goals at the end of life is going to be important in preventing some of these. Since, as I said, it's not only the physical things that cause terminal restlessness. A lot of times it's those unfinished business aspects of someone's life where they're not quite done yet. They're not quite ready to move on. And holding on to those can, quite honestly, lead to terminal restlessness outside of having pain or some other kind of physical condition. So other than that, I will open it up to anyone that has any questions. And thank you guys for listening. Check the chat. Okay. Does anyone have any questions? You guys can hear me, right? It's been quiet in here.
Yeah, great talk.
Oh, thank you. Anyone have any comments about terminal restlessness or what they've seen or any experiences of their own that could be beneficial for the group?
I think the one piece of advice that I would have is a lot of times, like you were saying with the anticholinergic, scopolamine patches go on and then are forgotten to be taken off.
Mm-hmm.
And then that can sometimes result in a never-ending cycle.
Yeah, that's exactly. Did you say scopolamine patches?
Correct. Yeah.
Yeah, and I don't know if it's just me, but here at our hospice, it seems like those oftentimes cause more cognitive problems than some of the other anticholinergic medications.
Right. And I think a good alternative would be Robenol could be used instead of it as needed for the secretions or death rattle.
Yeah, and I completely agree with that. It's a fine line trying to get these patients to be comfortable with, like you said, death rattle and things like that near the end of life, and trying to prevent some of these cognitive problems that patients experience.
Thank you.
All right. Thank you. And thank you, everyone. Have a wonderful weekend. And I will see you next week. Right now, we don't have anyone scheduled, but if no one schedules, I will pick it up and choose something else to talk about. Thank you, guys, and you have a wonderful weekend.